if you're chairing today, correct?
I believe so, unless did Martin join and I just don't and that I don't see him as I look through our squares.
No, he is not able to join.
He's not. Okay. Oh, I'm sorry to hear that. Okay. But hi everybody and good morning and buenos dias and also Yatsaya Bena and all the other languages that I need to learn. I'm so glad that you're here. And if you don't know me yet, I'm the vice chair because the chair isn't able to join us today. And that really excited that we're here to do this work. Thank you for taking this time during a busy time also. We've done this, maybe a couple housekeeping things that I'll ask before we start to move into things. And one of them is that your time, I know that you're stretched in a lot of different directions and there's a lot going on. If you have to turn off your camera for any reason, we understand. Please do whatever you need to do. You might be taking care of children, you might be taking care of parents, you might have to do anything. So please do whatever you need to do. Also, I will ask that we, there's a lot of people here who are MD doctors, there's a lot of people who are PhD doctors, and a lot of people who are otherwise highly trained but don't have the honorific of doctor, and yet we our work is better for everybody participating and for everybody's skills, gifts, training. So I'll ask that we refer to each other by our first names instead of with doctor, so that we can make sure that everybody feels welcome. One thing that we've done before that I think that is a nice way to build this maybe a little bit of sense of a virtual community is that we do our maybe our names, our pronouns, where we're calling from today, and then a personal part of it. So I wonder if we may do that before we do the formal agenda. And maybe I will start with that, and then I will try to call on everybody. And fortunately, unlike on Zoom where everybody moves around, that doesn't seem to happen as much. But we'll ask that if everybody can say, in this during a difficult time, but also in the spirit of many cultural religious traditions right now, there's a holidays that something that we're grateful for. So and that whoa, looks like I have to go camera off because my connection might have gotten bad. Grateful for is I am grateful for democracy. So I'm also the green chili. So the next person who I'll ask to introduce themselves, maybe we'll ask Alan if he would do so. I'll go camera off just to preserve bandwidth. Apologies for that.
Hi, I'm Alan Kleinel, a resident of Deming. Work 2 days a week, and I'm happy to be included in this meeting. I am old traditional pronouns and excited to be here. Thank you.
To Chris Woodward.
Hi, I am Chris Woodward. I'm an attorney with the Department of Health, and I work with the medical cannabis program. And my pronouns are he and him. And something I'm thankful for my good health, first and foremost, and for my friends and family. And that's it.
Wonderful. Thank you. Probably just that's it, but those are wonderful things to highlight. Thank you. And then maybe next, if Haley.
Sorry, are you?
Oh, I see that.
Am I on? I can't
start
see.
With, Haley
I don't know why I'm having so much trouble here. It's worked fine in the past. So can you see me or not see me? Or you can? Okay, because I can only see now half the screen, and some of you are cut off. So go figure. Love technology. Anyhow, I just wish everybody happy holidays. And I'm a physician, retired, long retired, and past president of the American College of Preventive Medicine and epidemiologist. So.
Thank you. And how about Haley Peterson?
Thanks. I'm Haley Peterson. I'm with the Substance Use Epidemiology section here at New Mexico Department of Health. My pronouns are she, her, and I'll say a silly thing I'm grateful for, but the Lobos had a great basketball win last night, and that was a fun game to watch.
I might mention, so you're Haley and I'm Hallie. So if you want to differentiate us whenever anybody's addressing us, that would be the easy way to do it.
Yeah, thank you. Thanks. And how about Eleni?
Hey, good morning. I'm Eleni Bukavalis. I'm an emergency physician in Albuquerque. I use she, her pronouns, and I am grateful to be on the clinical block that gives me a week off at Christmas to spend with my family and my daughter this year.
Wonderful, thanks. And how about Michael?
Hi, I'm Mike. He, him are my pronouns, and something I'm grateful for. Did someone already say? I think just took mine time off. It's gonna be mine too. I could use some time off, so I'm gonna steal that one again.
So this is Eileen again. I heard you say that maybe someone stole it. I would say everybody here deserves time off. So I say props to both of you and thank you. And then how about Elizabeth?
Hello, everybody. I'm Elizabeth Bissio. You can call me Libby. I am the health educator with the medical cannabis program, and I use she, her pronouns. I am grateful for airplanes so that this year at the holidays, I can go visit my family and bring my little baby to see her family. So,
Oh,
thank you.
wonderful. Thanks. And how about Matthew?
Matt Clark, Carroll County Emergency Services. He, him, and I'm just grateful for the family that I get to spend my time with. Not everyone can be in their hometowns and have family there, so it's just great being able to spend time with family all the time.
Yeah, it really is beautifully said. Thank you. And then I think that Matthew Pearson, excuse me. Are you available? Oh, sounds like maybe not. Okay. And then also Dominic.
Good morning, everybody. And he, him, his pronouns. And something that I just have to say, not only time off, because that is coming up very soon. We'll actually have a week, and not to make anyone jealous, but I will actually be on some beaches, so that will be a good thing. Especially for my sanity. Living in a landlocked state, it is always wonderful to go and see large swaths of open water. So for me, that will be a very good thing. But also really just family right now is very important. And, so I'm just really glad with every moment that I get to spend with people. Thank you.
Wonderful, thanks. And Gary.
Yeah, Gary French, he, him, his. I'm grateful for physical therapy. I just had some shoulder surgery 2 weeks ago. I'm at week 2 right now. I am, flying solo without my armband on today. So we'll see how it goes. But I do think that I'm recovering well because of physical therapy. And it's one of those unspoken marvels that I think really helps around surgery and around pain issues. And so something sort of unsung, but I'm going later today. I'm excited to go later today, and I'm grateful for it. So hopefully I don't slip in the ice, but I wore my boots today. So
Excellent. And glad that you're recovering. Great. And
yeah,
glad that you
thank
had
you.
this. Yeah, yeah. And let's see if Brenda, are you able to unmute yourself? Looks like maybe not. And then let's see, and Rosanna. It's not able to unmute yourself. And then Kathy.
Morning, everybody. I'm Kathy. Pronouns are she, her. I'm calling from Albuquerque today, and I am the IT project manager supporting the medical cannabis program. I'll follow in Haley Peterson's step and give a silly thing that I'm grateful for, but I'm grateful that the Patriots won against the Cardinals last night. Thank you.
Just
Here,
looking, yeah, I was gonna say, looking at the crowd, that didn't seem like it was silly, so very nicely done. Yeah, thanks. Yeah, great. And I think that we called on everybody at that point. If I missed you, the fault is entirely mine and it was not intentional, and I'll ask you to unmute yourself and to please consider introducing yourself, where you're calling from, if you wish to say your pronouns and something you're grateful for. Okay, I think we got everybody, so thank you. And apologies again that my connection is what it is, so I'll be turning my camera. Oh, okay. And there's looks like Mateo just put in a note into the chat. 2/3 of the family, not so much children, but some of the other ones, and it's a joke. We're grateful for comedy also too, Mateo. Thank you. Thanks. And let's see, so that's all of us in our introductions. And of course, one of the reasons why we do that is because it's a way to build community, decrease a little bit if there can be this disconnectedness, of course, virtually. Also, of course, we do our best work when we do it together and everybody's here because they belong here. Generally, silence should mean that you agree. It's easier also to speak up if we feel like we've made a little bit of a human connection and because our humanness really matters. So if this was something that you also thought was a meaningful a few minutes of your time, then maybe wherever you're doing your meetings that you'll do something similar. I'm sure that you will. So with that, I think that looking at the agenda, I think that you probably have it in front of you. Then having done that, then I think that we'll go next to our thank yous. And I'll turn it back over then to Dominic about that.
And thank you, Eileen. And while he's not present today, we just wanted to acknowledge Ryan Nix, who helped to serve on this committee for the last year. He has actually taken a position that in another state, and so he has moved at this time. And so with that, he resigned his position here on the committee. And so we will be looking for other individuals to fill that spot. And we also do have some other vacancies in different areas. So if you do know anybody who is interested in serving on this committee, please reach out to either Gary or myself, and we will see, about starting that process. But we really want to thank Ryan because he really helped. He stepped in a couple of times when necessary and is really interested in the topic. And he also has conveyed that, he doesn't want to just stop altogether, and he's going to check in with us and see on occasion what's happening, what's going on, and how he might be able to continue to help. So, but we just really want to thank Ryan for helping us with getting things started and being a part of the initial committee. So thank you to Ryan. Appreciate it.
Yeah, many thanks to him, and thanks to all of you, and thank you for that. Thank you. And then next on our agenda, an update from the medical cannabis program.
And that is again me, at least to start. We'll have a little bit more. So the first thing that I wanted to do, and I hope everybody will be able to see it, is just give a quick update as far as some of the statistics. So I am sharing my my screen. Give me just a moment to get to the right page. Go. And I do hope, can everybody see the page with the statistics on it? Okay, so I'm not going to go through in great detail on this because this is something that we put up every month. Usually it's about within the first half of the month after the month ends. So this, for example, is November. We did get it up a little bit early because this meeting, and also we had our medical advisory board meeting last week. So we wanted to try to have it available as quickly as we could, but it usually takes us about 2 weeks to get this up on the board or onto the website. So one of the things, and I'm going to highlight it a little bit more in another graph, is our number of patients who are enrolled in the program is reducing at this time. This was something that we anticipated with the advent of recreational cannabis. So this is not something that some people kind of have said, are you concerned about it? And the answer is no, it's exactly what we projected. We expect it will continue to decrease for a while. We don't know exactly when, but as we've seen with other states, when they put in recreational cannabis or adult use cannabis, their numbers also go down for a while, and then they level off and start to increase again. we anticipate the same sort of things happening with our program. So we're not worried about it. But on this particular file, and on these reports, what we have is we have both the active enrollment in an Excel table type form, as well as on a map, so that people can actually see what's happening across the state and get a little bit of a visual idea of enrollment throughout the state. We also have done the same with regard to percentage of individuals who are enrolled in the program. Now, this is the percentage based upon overall patient enrollment. And below that, we also have the table, so that it kind of shows you what that difference is, what that enrollment is based on the total enrollment in the program. And then we also on the table show, we tried to do it on the map, but it just made it look, quite frankly, it looked hideous because there were just too many numbers on it and became too confusing. But this does give you an example of what the overall population within a particular county is, and then how many individuals are enrolled by the county. So this particular table, people can also take it, and if they want to figure out other metrics utilizing it, it's fairly easy to do so. So like if, for example, someone wanted to find out or look at how much the patient enrollment in the county is based upon overall population rather than patient enrollment, they could easily take that and calculate that on out. Again, we're looking at expanding, and so you may see a map of that in the future. We're trying not to make things too confusing, but also having relevant points of data. We've continued, of course, with collecting our demographics. Those have not changed greatly over the last several months. From proportion-wise, those are very similar. We are looking at, for example, the Health and Human Services does what they call the data book, which they do every year, and we're looking at utilizing some of the information from there to do some comparisons with regard to the age ranges and ages of individuals who are in the program with some of the other data points that are from the data book. If you haven't seen the data book before, again, it's from HSD. I recommend you look it up and look at it. It is, I think, what, about 130 or 160 pages of various graphs, maps, and things about statistics regarding health within New Mexico. And it's just really a great source of data. And again, same with regard to ages. Our age ranges have not really changed or adjusted. I know one of our potential thoughts might be that with the advent of adult use, that we might see an increase in the under 21-year-olds, especially in 18 to 21, but we haven't really seen that at this point yet. And the reason for our thought behind why there might be a potential increase is because adult use is only available to individuals 21 years and older. So we thought we might see a little bit of an increase in that younger age group between 18 and 21, because they can enroll in the medical program with their medical provider signature and certification, but without parent consent. And so we thought we might see a little bit of a boost there. We have not actually seen that at this point. And so here's the graph that I really wanted to show you to give you an idea as far as our longer time enrollment in the program. As you can see, back in 2018, we were at 66, almost 67,000 patients enrolled. And then in 2021, and now this is month by month, we were at just under 128,000 individuals enrolled. We're now at 117,000 individuals enrolled. Our peak was actually, and we'll go back here, the next slide, our peak was actually in May at 135,388. And so while we've decreased by about 19,000 patients, this again is not something that we were concerned with. It's something that we anticipated, expected, and it falls very much in line with other states that have done the same sort of things, such as Colorado, Washington, Oregon, and all of that. And I see Michael nodding his head. Michael's looked at a lot of that national data and from other states. And so, this definitely falls in line with it. And we're, from our programmatic standpoint, we're not sure exactly where the baseline will be because we had some differences from those other states, such as with PTSD as a condition. And so we're not sure exactly where it'll be, but we should see it continue to decrease for a few more months and then start to increase. Now, one of the other things, and this is one of the announcements that we've made in the last week, is there are a couple of other factors that may affect the number of patients enrolled in the program or how they're enrolled in the program. And I want to go back up here just because it's a little easier of a graph to see. And this is on the 3 most commonly qualifying conditions. The top condition is post-traumatic stress disorder. Last week, we announced that we are adding and have added anxiety disorder to the list of qualifying conditions starting January 1st. And the reason we think that that may have a big change is really in this particular line of the graph with regard to post-traumatic stress disorder, because we know that there are a lot of patients who have expressed to us anecdotally that they have been enrolled in the program under PTSD, but their main reason really is anxiety. But because anxiety was not a condition, that they were enrolling under what they or their medical provider considered to be the closest condition for it. Michael's I think, going to talk a little bit later about the study we did and the survey. And one of the things that we found in that survey was anxiety was indeed a condition that many people said that while it wasn't a qualifying condition, they were using cannabis to treat their anxiety. So we do anticipate seeing some change as far as from the top conditions, simply because of people who may start enrolling under anxiety rather than under PTSD. Is this all making sense so far? Any questions? Okay, and then the last thing that I really wanted to update with regard to some of the changes that are happening is the program is moving more and more to an online enrollment process. We currently have over 17,000 patients out of these 17,000 enrolled through the online process or who are registered on the website. One of the things that we have made available to them starting this last week, and I will say on an official basis, it actually was there if people knew where to look for it, but we started to have an electronic card available for people to be able to utilize. And this is important because one of the feedback items that we received from individuals was that if they lost their card, that it was difficult to get a replacement card. And what people had to do, because we had to make sure that it wasn't something that was just stolen or anything else. If it was stolen, the process was the same, but we deactivated the card, for example. And so in order to do that, people had to fill out a form, submit the form, so they would be mailing it in. We would print a new card, deactivate the old card, mail it back to them. Just the mailing process, even if we process the rest of it in the same day of receipt, which quite often it was within 48 to 36 hours of receiving, so 2 to 3 days. But what would end up happening is they'd have to wait for the mail time, which could be a week or more. So that had the potential of a patient not having access to their cannabis and their medicine for a week or more because of just having lost their card. So now with the electronic card, individuals can go online, they can go into the patient portal. Once they register, they actually have access to their electronic card, which they can then utilize through their phone or other mobile device, go into a dispensary and purchase their cannabis. And so this is a huge step forward from that waiting time. The other advantage to this is, again, when someone is initially enrolling, if they enroll through the online process, they see their medical provider, the certification is done online, the patient receives an email, they complete their portion of the enrollment. Once that is done, we are being able to review and process those applications done online. Usually it's within just a couple of business days. Sometimes it can be a little more, but what we are letting people know is within about 5 business days, their application is fully approved. So long as everything is there. If it's not, they get a notification saying what they need to do, but they get it through email, so it's very instantaneous. And then once they are approved, they have access to their card through the electronic means. So once again, they are not waiting for the mail to get their card. They have access right away. This means that instead of the traditional time of 30 days to process a paper application with 5 days additional to print the card and put it in the mail, which then meant another week on top of that of mailing, this means that patients actually can start the process and complete the process in about a week's time. Or less, and quite often less. We've had actually at least a couple of people who they started the process in the morning and they were finished by the end of the day. So same day service. With that in mind, on the paper applications, we've also made a lot of progress on that as well, because while that 3 years ago was taking that full month to process, now only takes between 9 to 12 days, depending on what our volume is at a given point in time. So that process has still shortened, but people then still have to add another week or so just for the mailing aspect. So even if we get it processed in 9 days from the program, they're still waiting 2 weeks or more simply because of the mail. And that's not to knock the mail or the postal system, by the way. That's just the time involved in it happening. We also would see, especially now at the holidays, which is why this was so important for us to make sure that this function was available to people right now, is because the high volume during the holidays slows the mail greatly. And so sometimes that could be more than a week for individuals to get their card if they have to wait for the mail. This way, though, they're able to access it right away. Anyway, those are the main announcements that I had with regard to the program. Gary, did you have any announcements that you or updates to make? And I guess should say while Gary's doing that, did anyone have any questions? Okay, Gary.
Yeah, no, I didn't have any new updates. Again, I sent you the information with regards to the CPPC study, so hopefully you've had some time to review some of the information that Michael's going to present to us. And then Haley's going to also present some information with regards to the poison control numbers. So we've got a lot of great information. I don't want to detract from any of it, so I'll return the time to you, Eileen.
Oh, thank you so much. There was so much that, Dominic, that you presented there. Thank you. And I hope that as people get some time to think about that, that you feel welcome to, we can always come back to that as that comes to you, either in the chat or just raise your hands and ask the question, right? Because we're all here to learn. And yeah, and thank you. And I think, yeah, thank you also, Gary, so much for sharing the CPPC, that paper with us. That was really meaningful, and would love to be able to next hear from Mike about that.
Okie dokie, I'm going to share my screen. Feel free to jump in, guys, at any point if you have any questions or want any additional information. When I say that this is just a tithe of what is in that data, I think it's pretty accurate. We have hundreds of outcomes that we assessed. And so this is as much as I could in about a 15-minute period, what I thought I could get in for you guys. So let me just put this. So we work with the Department of Public Health and Safety, or Department of Health here in the medical cannabis program in particular. And so we did a series of studies this year that I think will give you guys some good context about kind of what's going on in New Mexico when it comes to medical cannabis from a lot of different unique perspectives. So not just in terms of qualitative, so we have a qualitative sort of focus on, it wasn't a focus group, it was more like a individual structured interviews with 29 patients. Medical patients. And then we have a quantitative survey with a lot more folks involved, but sort of an automated survey approach. And then we did another quantitative survey with actual providers who are recommending medical cannabis to authorized patients in the state. And so I think you'll see some really interesting insights here, some of which have already been referenced. Because for time purposes, I don't want to get too in depth on too many things, but I did want to provide some of these big picture sort of insights that were sort of discovered here beforehand, because I'm not going to go into too much depth with these in the rest of the presentation. And so I think one of the biggest pictures, folks really generally were pretty positive about their the New Mexico Medical Cannabis Program sort of website, the procedures and processes, both on the provider and patient side. And so I think that's something to note as as a positive. Also another positive in terms of, despite adult use implementation being full force at this point and pretty rapid increase, since April, we are still seeing really similar levels of medical cannabis access to cannabis. So there was a lot of fears for that there was going to be claims that there was going to be folks weren't going to be able to get access to cannabis, particularly medical patients, upon adult use being implemented, and that's just empirically just not what we saw. Having done data, taken data on this exact same measure prior to adult use being implemented and now after. We also saw that patient access to medical cannabis providers was one of the top sort of barriers, essentially, to actually getting access or enrolling or maintaining their medical status. And so obviously that's not something that the medical program is sort of directly in oversight or in charge of. And this is a complicated process, what leads to folks deciding to do that or not in terms of employers, occupations, we'll go into a little bit, but it's important to note that. The other big challenge noted was issues with the paperwork process. However, what I will say is, to say that is common amongst other states is sort of is beyond easy to say. Other states, it's every single state that we've done several states now with medical cannabis, and this is always a common, and it often is not particularly sensitive to, even if people, when things get changed and the forms get simplified, it's a very challenging thing. But the good news is most people said that the forms were not that big of an issue. So when we say that it was one of the top issues, it wasn't actually that prevalent of an issue overall, just relative to others. And so for the patients, these are just some of the highlighted qualitative statements made as a part of the interviews. Really focusing on some folks didn't love the idea that they have to see a provider to sort of recertify or maintain their medical cannabis card. And there's a little bit of not a lot of providers were, at least at the time of the survey here and earlier in 2022, were providing telemedicine. And so there was some geographic type issues with this, but there was less so than I was anticipating per se, with actually accessing the cannabis itself, more just the providers and that are needed to enroll and maintain a medical patient status. Again, just a really quick thing on the website. A lot of people really did like the way the website is set up. Thought it'd be helpful. Folks did rely on it a lot, even for educational resources, in addition to just okay, how do I get a medical card? And so I think that's important. There's also some comments about hoping that the department would work on stigma attached to medical cannabis use, which I thought was interesting. So this is just kind of a reiteration of a past point I made, just that the folks generally were saying this is almost identical to what we saw last time. Folks saying, hey, I don't have issues, but there are some saying there's a lack of stocks. Maybe their most preferred items aren't there, and with about 12% saying it's too expensive, which is quite par for the course. And to be honest, I'm surprised it's not, that comment is entire based on the social demographics of New Mexico. That's just as high, if not higher, in other states that I've seen for a very similar type of item. So that's good. So this is for the quantitative survey now for patients. So much larger sample and much more sort of complexity in terms of actually trying to piece apart what's going on with some of these issues. So what's interesting here is we see that cost becomes a little bit more of a sort of endorsed difficulty for enrolling as a patient. And then similarly for maintaining patient status. But we also see that in-person visits, similarly like the qualitative data, it's people who don't love coming back to do in-person visits to maintain their patient status. But we do see paperwork fairly lower now, and so that's good. So it's more that paperwork potentially earlier was more associated with the sort of issues of getting enrolled as opposed to maybe maintaining status. So no huge issues there. Now we're going to kind of transition here into more kind of the reasons, the context, the patterns, characteristics, et cetera, of cannabis use. So we see that roughly half of folks, a little over half, right, say they're just using for medicinal purposes. Now that's sort of broadly, right? It doesn't necessarily mean that everything is a qualifying condition. And as we see below, about a little over half are using both for qualifying and non-qualifying conditions. In other words, when I say medical cannabis conditions here, I just mean that they're saying I use medical cannabis for this health symptom or condition, whether or not it's actually a qualifying condition in New Mexico or elsewhere is not necessarily relevant to that one. So a lot of folks are sort of, using medicinally, but they're, also using medicinally for reasons that aren't, formal in terms of their authorization. So this gives you more details on that exact kind of breakdown. And so it's kind of interesting because the more folks sort of have these, the more symptoms that they sort of use medical cannabis for, they're reporting sort of a greater propensity to use for more non-qualifying conditions. That proportion of medical cannabis use as they have more medical conditions, which is somewhat intuitive, right? That they're starting to generalize that use across not just what they've been approved to do, use it for, but for some of these other conditions that they might find it helpful for. So on the left here, we have two, I apologize for the kind of the size here, but there's a lot of conditions in New Mexico, you guys are well aware. So for qualifying conditions on the left and non-qualifying conditions on the right, for the non-qualifying conditions on the right, these are obviously not exhaustive, but we try to get as many in as we thought was relevant and feasible. And so we generally saw that some fairly consistent stuff on the left side here for the qualifying conditions in terms of it being fairly consistent with what we would see in the actual data, the qualifying data that Dominic reported earlier, and that's in the actual data. But then it supports his argument that anxiety was a top concern here. And given that pain is actually so pain, people are saying, that they could be saying that my pain isn't severe enough that I can't get a recommendation, or I just haven't bothered to do so. But of the approved conditions, anxiety, of the non-approved conditions, anxiety is the most prevalent. Essentially, that's thought on the anxiety and sleep, excuse me, are the two most prevalent. And you can see at the bottom, opioid use related issues is actually quite rare, exceedingly rare actually, which is also interesting. I think we were expecting a little more common reports on that, but that's the data. Sorry, there we go. Okay. All right, so we also got a few sort of interesting inferential findings. And so, it's weird. So those who met with a primary care provider or like sort of a specific medical specialist that they kind of sought out, which is about half the sample, were actually, when they're getting their medical recommendation, had a lot less problematic cannabis use. They use less recreationally, so by default, more of their use was focused on medical use, and they actually use more qualifying relative to non-qualifying conditions. And so, it's hard to say here because it's one point in time that we can have this data. So if it's the chicken or the egg, but it's at least suggestive, right, that folks that are sort of prioritizing getting potentially access to better care medically in terms of the context in which they're getting their cannabis recommended might have better sort of outcomes, might be using cannabis in a way that might be more ideal for them. Great. And my computer's a little laggy right now. There we go. All right. So this graph's a little bit intense, so I apologize in advance. What this is saying is if folks that basically, if there was what we're calling them carefulness reasons, ideally it's like basically saying like, I'm careful about I don't use a ton before I go drive, or before I do something that, it could be dangerous to use cannabis before, they're cautious about it. And so those folks that report 0, right, are more likely to have experienced a provider that did not present risks. Those folks that do one of the two reasons that are most common in terms of like, basically harm reduction approaches, making sure they're careful about their use, are about 50-50. But so the provider, their providers were better at presenting risks of cannabis. And then those who had 2 reasons, it's 80%. It's a pretty systematic effect that again, sort of folks that are getting this better sort of interactions with their medical provider are also in turn, more likely to be engaging in like sort of harm reduction or, sort of potentially like low risk or risk mitigation behaviors at home or in everyday life. And so I think that's an interesting sort of finding here. And then the last, let's see, what's this thing? Last thing is providers. So these are the medical providers, about 38 that responded, a little bit older in age. A third of them over a third had doctorates, almost all had masters. A surprising number were actually themselves active patients. That's something to consider. I'm not sure what the base rate of that is in the actual medical cannabis patient group or amongst those who recommend. I'm not sure how many have medical cards, but you can see too at the bottom the employer type. A lot of private practice and health center, like a kind of an outpatient clinic, were pretty common. So these are the number of patients on the x-axis. So they're sort of binned, and the frequency. So you can see the frequency is the number, I guess, on the y, and the patient number is the number of providers on that vertical axis here. And then on the x-axis here, this horizontal one is the number of patients that fulfill that same frequency. So you can see that about 40 and then 100 are the 2 most common. So there's this really interesting sort of like divide. Although the average is 50 across the whole sample, you see this sort of split distribution where oftentimes, if you look at essentially folks that about, let's see here, almost half of the sample basically either has about 40 patients or about 100 patients. So it's a bimodal distribution, if you will. So here what we're looking at now is how do providers make decisions when they're recommending medical cannabis? Are they, what factors are they considering? And so, what we actually, there was no one that put that they received training by their employer, which I thought was pretty interesting, because to say that 37 of these folks, and not one of them, they experienced that, and these were not mutually exclusive. These were a select all. And so generally what these folks were doing was focusing on the patient medical condition, that particular individual's prior experience with cannabis, and then third was actually referencing scientific or medical journal articles in like the peer-reviewed literature. So this was one of the more intriguing findings of the study. So when patients were asked whether their medical provider or the medical provider who recommended medical cannabis discussed these outcomes with them, whether it's ever been discussed with them. So cannabis use disorder is the first, and then drug under the influence of cannabis. And we also have other basic, about 18 to like 1 in 6, and then about 1 in 9 said that they discussed drug under the influence. So very rarely. But when you ask providers, not the exact same question, but a similar question, the percent that said they warned patients often or very often, which were 2 of the 5 responses, they said basically every time for drug under the influence, and 2/3 of the time for problematic cannabis use or cannabis use disorder. So obviously, right, there's this pretty notable gap between what the providers and what the patients are saying. So it could be a bunch of things, right? It could be that the patients, weren't, on average, maybe patients weren't attending as well as they thought, and it was said quickly, and they just didn't, they don't remember it. Or maybe the providers are thinking it, but not saying it as much, right? And so it's hard to know what that discrepancy is caused by, but it's certainly worth noting that it's a pretty notable discrepancy. And given that we're finding that what providers do and when that information is processed by patients, good things generally are happening, or at least it's associated with good things. And I think that's important. I think really positive signs about the providers in general was that most of them said that they were at least moderately, if not very interested in like basically continuing learning opportunities, like their CEUs that could be focused or related to medical cannabis. And that almost 90% of them were already accessing such CEUs, which I think is positive, such that they're sort of already engaging to some extent in educational, potentially, hopefully, scientific and clinical resources that are going to help them make better decisions, together with their patients. There was also, I think, based on that factors list, a pretty nice propensity for providers to focus on patient-centered sort of outcomes, which I think is particularly important in the context of medical cannabis, and that the complexities that are there and the lack of information in terms of what is, somewhat effective, partially effective, et cetera, very effective. I think that's important that the patient-centered outcomes are focused on. And I think a lot of folks said, not all, but about a third, I believe, said that the key barrier to their practice, like sort of being better at doing what they're doing as a provider, was not really having access to scientific data on medical cannabis benefits and harms. So about a third of them said it was their chief barrier. And now it's hard to know whether this was a little bit discrepant based on how much folks were actually using scientific data in their decision making. So the one kind of conclusion is that they're saying that the current data isn't good enough. So I can't use the current scientific journal articles. They don't inform me well enough to make that my primary sort of reason of making a clinical decision. And so I want to be able to do that, but it's currently not good enough, is one potential sort of explanation for why there was a little bit of that discrepancy between what they were saying here and earlier. And so that is the big picture sort of overview. So please let me know if you have any questions or comments. I would appreciate it.
Michael, I actually had a quick question, and it was a thought maybe for inclusion in future surveys. But it struck me when you were talking about the opioid use and how it was actually lower as far as one of those factors that you were talking about on there. And I was wondering whether or not it might be an issue where individuals who are using opioids on a regular basis might actually be getting excluded by the medical providers for certification to begin with. So they may not have even been a part of the survey because they're not actually enrolled patients. So I'm just wondering if that might create a bias. So something more to think about than anything else. That just sort of struck me when you were talking about the opioid usage.
No, that's a really good point. So in let's see here, our national data, we basically, I think, are seeing more what it supports what you're saying, Dominic, is that we get a lot more folks that are using opioids, using cannabis in relation to their opioid use. So because it's not necessarily just patients, we do get patients in that national data set, but it's not just patients, and it's a much broader range of folks. And so folks actually have been explicitly saying, I use cannabis to replace or deal with withdrawal symptoms or cravings or et cetera, much more frequently in that sample. So yeah, I think your point's well taken and pretty accurate in terms of what's happening, I think.
Great, thank you, Mike.
I have a question. Do we have any idea how the respondents to these surveys compare with the database of users, if you will? So we have some sense if there's some bias in response.
So you say users, you mean just everyday folks that use cannabis in general? Or
well, either users or providers. So you have, what did you say, 38 who responded as providers. How many are actually providing, and how do their demographics differ, if that's the simplest thing we could find? Or
right. So for providers, I mean, I don't really have data on if you're asking for representativeness, I'm not. Is that what you're asking about, basically?
Yeah, how generalizable are these results to the population?
Got you. So I think in the provider one's tough, I will say, because there's obviously selection bias in terms of who responds to it. What I can tell you though is generally when compared to our national survey data, which does get population representative data, whether it's, across these outcomes, we do tend to see fairly similar findings. I haven't explicitly looked at each one of these, for example, but so it's hard to say like if this is exactly how representative they are. Actually, like in terms of population representation, it's difficult to say because I don't have access to that data for the providers. Now, for the patients, it does tend to be pretty well. It does correspond well in terms of at least demographic distributions. The providers are tough. But I think a lot of it is trying to make inferences based on, like I'm not sure how many, Dominic, how many providers are there in Mexico? I thought you guys, was it?
You mean overall medical providers? That I'm not sure of,
or like,
off the top of my head.
Do you know how many that prescribe medical cannabis or recommend?
Well, it sort of falls into two categories: the individuals who are certifying, just one or two patients within their practice, and then the others who are certifying lots of patients. So you end up getting skewing on that either way. But I think one of the most important aspects of this is these were all individuals. The providers are all providers who are certifying people for the program.
Yeah.
So while there is the potential for some bias, they are representative simply because they are certifying patients. So we weren't asking providers in the survey who don't certify patients for the program.
Right.
That's a whole nother study. That's a whole other survey we need to do.
And I think part of it too is, again, it still could be a biased sample, but I think actually the percentage of folks that are regularly providing, of those who are regularly recommending medical cannabis to folks, was actually a very, very large sample compared to what is in the population, if that makes sense, versus like a general cannabis use sample compared to the population, if that makes any sense, which I think helps at least some with the generality. But I do think it's important to follow up on these and the findings that are more within the group as opposed to making broader statements across other groups or to other settings. Should be qualified a lot.
It raises a lot of interesting questions. For example, if the providers are also discussing non-qualifying and qualifying things.
Yeah.
One of the questions that comes to mind just looking at the data, while you mentioned cannabis use disorder and driving issues as two potential safety issues, but what about medication interaction issues or medical condition interaction issues, for example, which are, again, things that we should be concerned about in looking at the safety of the use of this. And I don't know how much data is out there about interactions. I do know when I go to Medscape and look at prescribing interaction questions, they'll talk about cannabis to say, be aware of these interactions, but I don't know how much data is behind that versus simply reporting to the FDA, which we know doesn't require more than a single incident. So,
yeah, that's a good question. Unfortunately, when we set up the questions, we had different risks presented. It's like the CUD, the cannabis use disorder, and the driving of the influence were similar, were the same presented to in terms of the risks themselves to the patients and the providers, but we had different ones, unfortunately, for the providers versus the patients. So that's why I just didn't match them up there. But we did have a lot of other basically other interactions, subbing in for cannabis for other prescriptions, psychosis, other potential things that were, by and large, it was roughly between 40 and 65% in terms of what providers were saying they do present risks about that. They do talk about that. And again, folks on the patient side were saying, I rarely, if ever, hear about that.
Interesting, you could break down the data by age because older people have more medical conditions and are on more medications, see if they feel like they're getting adequate discussion of at least safety issues broadly, maybe that would help.
That's a really good idea. Yeah, that'd be a smart, cross-tab sort of approach. Yeah, I like that.
Mike, may I also ask, that was such a great question. That was such a great discussion. And of course, it made me think back, and you may have presented this, which is also by indication is.
Yeah.
Like that
that's
would be the,
that's the
Go ahead.
ultimate, yeah, like kind of that's the ultimate question. Yeah. So I think honestly, because like we have data right now from we just recruited like I think 13,000 people who've used cannabis at least in the past year, and about 40% of them are certified medical patients across the US. And so that's one where we might actually start to be able to have the sample size, and it is a representative sample. So we might be able to actually start to get at like, okay, per condition, what's really going on here. So I wish I could tell you more about New Mexico specifically, but right now I think it's the scalability of it's tough.
Thank you.
And just so everybody,
oh,
no, go ahead.
Oh, thank you. On one of your slides, you indicated one of the things that the patients had said was simplified program resources. I don't actually know what that means. That was one of the things that the patients had indicated that could be helpful to them. The other was stigma reduction. And I wonder if there's any more information that you could share about those.
Let me see. So this, I think it was the first one. I think is more about like just forums and challenges with like that process of navigating that. And I think in terms of exactly, some people talked about the actual like one-page medical cannabis enrollment form itself versus other people talked about challenges with other parts of like sending the card in. I mean, it wasn't uncommon though for folks to like have be saying I wish I didn't have to do blank, but like they didn't actually have to do that to get their medical card. So it was like a really but then you have to go, okay, well, why is that? And then you kind of go down a little bit of a black hole there. So it's a little bit challenging to say exactly. And I think unfortunately there was a lot of different responses on that, but it's a good question. The stigma part generally I think was folks, I think there was a couple comments to the point of like feeling judged for basically getting treated for, getting recommendations for medical cannabis. And along the gestalt of like, along the lines of like drug seeking or something like that, when they felt like they were, being judged with, I think, a comment or two that was focused on that. Although a lot of times folks would, I think if I recall correctly, would just kind of say like, feeling stigmatized or stigma and kind of leave it at that, at least in the qualitative.
And of course, many of the diagnoses that people have that are resulting in them getting certified are also diagnoses for which people often carry a stigma. Like PTSD,
exactly, yeah.
right? Like chronic pain, like having an opioid use disorder.
Anxiety, yeah, absolutely. Talk to your,
Yeah. And I feel like I should also clarify that when I asked that question about the simplified program resources, I didn't mean it as a veiled criticism. I think that actually, it sounds like when I compare this to actually using my own private insurance to try to see, as an English speaking person who's highly educated, who also like has money, the difficulty navigating our healthcare system is astounding. So I don't mean that as a criticism. It sounds like actually it's probably much smoother than it is. Yeah. Anyway, I'll stop there. But I'm sorry I interrupted you, Dominic.
No, not at all, Eileen. And sort of just what I was originally going to say is I also want everybody to know that some of this and what Michael is presenting is really the preliminary from this study. I mean, as far as it's not the preliminary data, but this is really just one of many studies that we're planning on because we're going to be doing more. And so what this study really helped, and these surveys really helped us to do, is stop and look at what additional questions do we need to ask? What areas do we need additional clarification? And so there will be others here moving down the road. I know we've already talked about various things that we need to do, other questions. It's part of why anytime Michael and I talk, it seems we have about 100 more questions to add. So of course, with doing research and studies, that becomes, well, that has its own issues and problems. But this particular one was also very important for us because even though I appreciate what you're saying, Eileen, about the process probably being fairly smooth, what it still tells us is perception out there is that for many people it's not. And so we're going to continue to streamline and to also provide additional information to patients and prospective patients and the providers, so that we can actually get rid of some of those perceptions that might be more negative simply because people don't realize it. One of the ones that really kind of came through was a few people who have made comments of, oh, I have to mail in my card to get my new one. And it's like, where did you hear that? And because that's not a part of it at all. And so different things like that that have been misperceived or misinformation floating around, we're going to try to do our best and to do a better job of combating that. And so we're just going to continue doing it. And then the other side is just as far as from a stigma aspect, we always are looking at that. One of the things that we hear a lot anecdotally on the phone, and again, an area we'd like to explore a little bit more, is actually when patients are saying they go into their primary medical provider, and that's the provider who actually is making comments or statements like, I'm not going to certify you for this. I don't believe in cannabis. And then patients, of course, are taking that from a stigmatized approach, or, feeling stigmatized. And they very well may be, but it may also be other systemic issues where we have heard, for example, some large organizations have turned around and said, we're not going to certify this. We see it on a federal level. For example, IHS and the VA cannot. Their providers cannot certify. So just even a doctor saying, sorry, I can't do that, or even talk about it, might be perceived by that patient as stigmatizing. And so again, this is about getting that information out there, doing more education, and we're going to continue doing that. But this survey and study really helped us to be able to say, okay, here are some of the main areas that we need to do some more education. So from that point alone, it was very valuable. But there were many other valuable points within this that we're seeing among the data, and that we think this is going to be a really good basis for our next moves forward with regard to research and studies. So thank you.
One of the things that's cool too that I was just going to add that we've been working on kind of came out of some other work we've been doing with another state, but I think is going to be really relevant moving forward is, I don't think anyone else has done this. Like, we've talked to researchers doing a lot of different studies, epidemiological and otherwise, but we finally got a survey approach where we can actually realistically, with large numbers, get all the way down into individual instances per product type of cannabis use by dose, so milligrams and THC. And that's, I think, going to be the future, like, in a lot of different aspects of medical use, not necessarily say it's going to be everything that we're doing with New Mexico, but just something to consider is that importance, because that's ultimately going to be, there's some increasing evidence that that's a milligrams THC as a unit measurement, as a type of way to measure a unit of cannabis is going to make it a lot easier. And we're finding data that's really validating kind of itself in comparison to these other outcomes, cannabis outcomes, that might start to get us closer to like, okay, if you have X condition, you might want to stick in this range, roughly, to maximize benefits and minimize risks. And so I think that's an exciting sort of frontier, just as an aside, that's kind of dovetails with some of our other comments, that I'm excited that we might be able to provide that to patients eventually.
In the spirit of additional questions to consider, I found that, Dominic, what you had said was really intriguing to me. And I've also had the experience about people asking for things that are clearly, there's other best practices for treatment. I'll give the example of my dad had lung cancer, underwent a reg resection, and asked about medical cannabis. And I said, actually, there's inhalers for COPD and also pulmonary rehab. And that those are things to know, that are pulmonary rehab in particular is known to prolong life. And that was just a representative example that I feel comfortable sharing, but other people have asked for things that like for sleep apnea, which the American Society of Sleep Medicine recommends against. And so I feel like sometimes it could be interesting to probe what are the reasons why the clinicians are not, and then what is the disconnect there? Because it could be medically invalid. It also can be medically and psychiatrically valid, right? Or why are you laughing, Mike?
No, I'm sorry. I just that's I mean, it's $1 million, it's like one of the $1 million questions. It's like one of like 5 or 6 kind of $1 million questions that in medical cannabis that are just like, people all over the world are, banging their head against the wall, trying to figure out, and just that, like, it's a really good point. And it's, what are the medically validated and invalidated ones is, if you ask, 20 scientists from NIDA these questions, they're going to disagree on most of them, I mean, and that's the problem, and so it's like, but we do have some data in here already, though. Actually, we did ask, like, did you try to the provider, did you try the available treatments first? Like that are like alternative treatments that are sort of like first line, second line kind of first, or did you just like go straight to cannabis? And so there was not a lot of propensity to try other things, but it again is, you have to weigh that against what are those conditions, and is there a lot for those things, to begin with, right?
And I know we still have the other presentation about the other data, so I don't want to keep going. I think we could actually talk about this. And again, it's the issue. Every time we get Michael on the line with us, we end up going well over our time just because there are so many questions and items. And Eileen, in this case, you're really talking about a perception survey. For example, do the patients think that cannabis would be a good option for them for a particular medical condition when the literature and their provider and everyone else says no, or vice versa. So we really have to, there's a lot of study and research going forward with regard to cannabis, and hopefully the bill that was just signed by President Biden, passed by the Congress, will actually be beneficial and help with that research, because it really is going to allow, or at least is supposed to allow, for more studies with cannabis itself, so that we can actually start gathering some much better data than what we've really been able to do in the past. And I see us continuing to do the same. There's a lot with not just the medicine, but also behaviorally and perceptions and risk, especially, that we really need to explore. So I look forward to that, and I think it'll be really good. But anyway, that just wanted to sort of bring that on up. But we only have about 18 minutes, so.
So I'm so sorry that then I asked like 100 questions there, and thank you for humoring me with all of those answers. And
no problem. No problem at all.
And that was great. And thank you. And I think that then next that probably then would move us to the poison control data. I'm excited to learn from you, Haley.
And I should say, if anybody has questions for Michael, I know this is putting him on the spot, but I also know he will say yes no matter what. But, we can always forward them to him. If you don't have his email, just send them to me, Libby, or Gary, and we'll get them over to Michael. So
absolutely.
All right, can you all see my slides here? Okay, great. So thanks for having me on the call today. So I'm just going to give a very brief presentation on some of our Poison Control Center data. Let me let it move forward. There it goes. All right, so for our cannabis-related calls reported to the New Mexico Poison Control Center, we actually established weekly reporting with our partners at the Poison Control Center back when markets opened. So just before markets open, we discussed with them that it would be nice to have weekly reporting. Something really alarming came up. There's a few things to note, though, about Poison Control Center data. So calls center can be made by patients' caregivers, so they might call center themselves, especially since that number is included on packaging. So they might call because they have a concern and talk to someone directly at the Poison Control Center and see how they should proceed themselves. But also healthcare providers can call or report cases to the Poison Control Center. So you may have a patient that shows up to the emergency department, the healthcare provider decides to call the Poison Control Center, either because maybe they're concerned about the specific product and whether or not something should be done with that specific product, or maybe they just want some guidance on how they should proceed with treatment from there. Another thing to note is that reporting cases to the Poison Control Center for healthcare providers is currently voluntary. So that's just something to keep in mind, that it's not required that every case be called into the Poison Control Center. And then one final note I'll give just before we look at this data is that we did release a health alert just the day before markets open for the adult use market. And so we worked on that with, of course, medical cannabis program and the Poison Control Center. And we created a health alert to go out to healthcare providers so that we could give them a heads up that, hey, with markets opening, you may see more cases related to cannabis and in particular pediatric exposures to cannabis, in particular edible products. And so we just wanted to give providers sort of a heads up that they should keep that at the front of their mind if they see a child that's presenting with certain symptoms like a child that's lethargic, that they should keep in mind that they may want to ask about cannabis exposure or even test for that. Okay, so keeping all that in mind, today we'll look at some data from March 2022 to November of 2022. I unfortunately realized just before the meeting that I don't have January or February data at this time, so I'll try to get that if we want to look at this data again at the next meeting. But from March to November, we had a total of 178 calls, and 118 of those calls, so 66%, were related to an edible product. So edibles continue to be the majority of calls to the Poison Control Center. And then exactly half of those calls were for pediatric cases that were age 10 or younger. And then we do have the annual number of calls for 2003 to 2021. I don't have the same breakdown by age or edibles or type of product, I should say, for this data at this time, though I'm sure we could get that at least for some of the more recent years, if that's something we want to look at in the future. But this chart, I think, is very interesting, especially seeing how the number of calls increases after 2014. So January 2014 is actually when sales began in Colorado. So I think that's something interesting to keep in mind, that after that year, we start to see an increase in our calls to our state poison control center. So keeping this trend in mind, and again, for our March 2022 to November 2022 data, we have a total of 178 calls for that time period. So then looking at the monthly calls in 2022 on a graph here, March 2022, the start of the graph would be the month before sales began for the adult use market. And then April 2022 would be our first month of sales. So we did see a significant jump in the number of calls these first 2 months of sales. And again, there's things to keep in mind there with that health alert going out. It's possible that more cases were reported because it was at the forefront of healthcare providers' minds. And then also just considering that there were likely a lot of new users to the market. And so potentially, that led to some naive users experiencing some issues related to their sort of new cannabis use and maybe looking for guidance from the Poison Control Center for that reason. We do see a significant drop in calls in June of 2022, sort of starting in the summer, which is very interesting. I'm not exactly sure why there's such a significant drop there, but that's sort of an interesting thing in the data. And as we go forward, we'll get more trend data and we'll start to see some maybe normalization in the data. And so this is certainly something we'll want to keep tracking over time. And then I thought it would be interesting to also chart the percentage of calls related to an edible product for this monthly data. And so you can see we really hover between about 50% to 80% each month of the calls being related to an edible product. So I think there's still a lot of education we can do about safe storage, which I know the medical cannabis program put together a wonderful document emphasizing safe storage. So I think the more we can get that message out there, the better, certainly. And then last graph I'll show today is the percentage of cannabis calls in our pediatric cases, age 10 or younger, for the monthly data. And so you can see we sort of hover month to month around 50% or so from month to month of those calls being in those pediatric cases. So I just wanted to give a very brief presentation because I know there was a lot to discuss today. Before I take questions, I will just mention we are working on a public-facing data dashboard with the Poison Control Center. We're hoping that that'll move forward. Hopefully in the new year. It's kind of been stuck in contract limbo, but we are they've been such a great partner And so we're really hoping we can get that public-facing data dashboard to make this data very easily accessible for everyone. All right. Hopefully I didn't take up too much time. Any questions? And I can't see everyone on the screen. I'm not sure how to bring up everyone again. Let's see if I can figure it out. Oh, there we go.
No, and I just like to say thank you very much, Haley, because this was data I know that we had been talking about and had been requested. And I think that the trend lines are very interesting, even already. I think you're spot on with regard to the beginning of sales in Colorado back in 2014. I almost would wonder whether or not we see whether or not poison control can break out into different metro areas or regions of the state. So we might actually be able to see whether there were more calls, for example, say in the northern border counties with Colorado, like in the Farmington area or Raton or things like that, at that time compared to earlier versus, more southern counties if they had more or less. It's sort of seeing some of that breakdown because that might help a little bit with that. And of course, the interstate system always, sort of messes that up a little bit because we always have that direct line through I-25. But I think that might be helpful if there's a way for poison control to break that out based off of maybe counties or metro areas even, or just even
Yeah.
regions. Do you know if
Yeah,
that's a
that's a great
possibility
point.
or?
I'll ask. I'm
Okay.
sure there is a way because I know that in the current data I'm receiving, they ask about county of residence. So I'd like to think they'd have that going backwards as well, because that would be one of the basic points they would collect.
Great.
So I can ask about that certainly, but that's a great point. And Hallie, you have a question?
Yeah, I'm wondering from a procedural perspective, for example, do emergency rooms report to poison control also? And is it mandatory if they do? And/or would there be more data we could gather if we surveyed emergency rooms similarly in some way?
Right. Yeah. So right now, case reporting is voluntary. So I have seen some calls where it's come from a provider in the data. So the provider may be looking for guidance on how to treat the patient, or perhaps just wanting to note a certain product that caused the issue. So there has been some healthcare provider reporting happening in the data, but it's voluntary. So that's something we could also as a committee consider, whether or not we would like to try to move that to mandatory reporting. I'm not sure exactly the processes that would be involved in requiring reporting, but that's something that perhaps could be considered, because I know there are other cases that have been made, or other conditions, I should say, that have been made mandatory for reporting for providers. And then the other thing I'll say is there is syndromic surveillance data. I haven't had the opportunity to dig into that data more, but that is something I'd like to be able to look at. Syndromic surveillance data would give us emergency department data. And there are, the caveats that can come with that data system as well, but I do think it would be interesting.
And I can just comment on that as well. Anecdotally, Hallie, as an emergency physician, I was going to say that I think we are probably vastly underreporting, particularly in the case of adult patients. I think anecdotally, most emergency physicians would call in the case of a pediatric overdose. But I think there are probably a lot of presentations that are maybe primarily psychiatric appearing initially. And if cannabis were a contributing factor, it would not necessarily occur to us to call Poison Center. And so there may be some underreporting from that perspective, I think.
Thank you.
And Eileen, just really quickly, you had asked a question about counseling on safe storage required. It is not, but we do have educational materials on our program site about safe storage in both English and Spanish for really anybody, patients, providers, anyone to be able to utilize. So just wanted to point that out. I think there's a few other questions though.
This is Matt. I'd just like to make a statement of, I think we should lean towards mandatory reporting. I need to get with my ER to see if they did, but for October, they were seeing edible increases in their peds, 3 to 7 year olds. And I said, I'll have to find out if they did report. Chances are they did not, though.
So this is Eileen. That was a great presentation, and thank you everybody for your questions and your comments, and Haley, really great work. And maybe I'll ask if anybody has any more any additional questions or comments for Haley before we move next to the next item on the agenda. Those are discussion of research and resources. Oh, great. And Kathy, thank you for adding the educational materials link. I hope everybody can take a look at those. Yeah, and share them widely, it sounds like, right? That's a great step too. And then next, the discussion of research and resources, which I think is led by Gary, but am I okay? I'll mute myself.
Yeah, I'll jump in. Everyone, Zotero, we are continuing to add documents to that site. So I included a number just this past week, and I have seen others of you contributing as well. So, check in with the site. If you got a free reading Sunday, check in on it, see if there's something there that is of interest to you. And of course, as more information and research data comes out, we'll be hopefully sifting more articles over that way as well. One other thing, and this probably wasn't an announcement I should have made earlier with regards to some research, is that we've been holding sort of an EchoLight. It's a cannabis forum meeting for certifying providers. And we've been doing this on every other Thursday, and we've had 3 of these, and I think you've received the invite for them. Some of you have attended, but we are going to continue those in January. January 12th would be the next one, and so we'll be able to continue to address some of the issues that the study shared with us with regards to encouraging our providers to have, more impact on their patients. So again, those are 2 things that we are doing with regards to getting the word out there. Again, articles to Zotero, and then please attend the forum. And I'll of course send invites for that out again. But other than that, in the studies that we discussed today, I don't have any other announcements with regards to research.
Thank you. What questions do people have for Gary on that, or comments? Looks like on the chat, which is great. Thanks. And then anybody, maybe I'll count to 5 to give you a moment if you want to unmute yourself. Okay, and then next, any other items from the committee members? I know that I'm going to ask you to forgive me because I think that it might have been Hallie who had asked about this before, but about if we at some point we're going to have an in-person meeting. But I know that there might be other items as well from the committee members. So I'd like to pause to hear what those are from you.
So I had another question or two. One was, we had briefly discussed 2 or 3 meetings ago that we should start outlining information that we want to put into our report. Granted, it's a couple of years away, but gathering the data to make sure, or at least moving toward gathering the data to make sure that we can fill in those tables, if you will, would make sense. And I was wondering if any work had been done on that to this point. And I guess my other question is there an initiative through the State Health Department to work toward integrating any data availability there might be, so we can cross-check the drug overdose information, or at least the poison control information with the survey or whatever. I'm just making things up right now, but whatever might make sense. I don't know what other databases are out there other than have been presented in this forum. So, and even ER data, symptom data, as was mentioned earlier, and that kind of thing.
Holly, those are really good questions, and sort of to answer them real quick, that's one part of what the Zotero with getting and gathering those research, but also one of the things we're doing is from the department and the department staff is gathering the data on the points that are specified in the statute for the areas to look at. So that's where some of, like, for example, the information today about poison control really comes from, and we'll continue to gather that, looking at for the emergency rooms, gathering that information. And as far as sort of all of the data, because there is so much, I can tell you there is a big move right now within all of the various state government agencies to do a data, I don't even know what to call it at this point, but to try to make those connections with the different data sources to really be able to say, okay, where do we have potential health issues and health connections? And I know between DOH and Health and Human Services, those have been moving forward to try to be able to make some of those connections that you're talking about. The speed on that, I can't really answer to. I just know it's an ongoing process, and the databases are huge. I mean, just when you look at some of the ones thinking about, vital records and Medicaid, type databases, those are just really, they're quite broad and very comprehensive in many ways. But looking at those and really trying to get that data connected is something that is happening, not just through Department of Health, but throughout the state overall.
So that's great that that's happening. And what we might do is, if we can put together sort of the outline and talk about what the priorities are of the data that would be most useful, at least for the upcoming report, even though it may be 2 years away, then we can say, okay, what are the databases we want to encourage along more completely, and those that we maybe aren't quite as important for.
Right. And and just so you know, some of those are ones that we already are working on. I mean, as I mentioned, like the ER data, looking at the data about DWIs and traffic accidents. So connecting in with some of those law enforcement databases as well. But I think you're correct on that. So what I would suggest, just since we have people who are having to drop off, and thank you, Matthew, as well, for being able to be here. But what I would really say is maybe at the beginning of next meeting, really having that conversation and saying, here are the different types of databases we have. And what we'll do in the meantime from the program is see if we can get more information about what connections are there or what the plans are regarding that to connecting the current existing databases.
Great, thank you.
That was great. Thank you. What else, team?
And the other thing I'd be willing to do is, if being in Santa Fe, it makes it easy enough, but I'd be happy to come in and sit down, and if anybody else in the area wants to, and just start working through some of the questions, to help sort of outline all of this. I know it can be quite a task, but just spend 2-3 hours one afternoon, and maybe that's another way to sort of kickstart the whole thing.
Sounds good to me.
Assuming my shoulder's not operated on also, Gary, that's
Well, maybe that'll be a part of your recovery process, as we can come and keep you occupied.
Excellent. Thank you. Colleagues, anything else?
I'm sorry?
Oh, no, just thank you. That was really meaningful. Thank you. And yeah, thank you. And I'm looking forward to the ongoing follow-up for that. Colleagues, is there anything else for new business or new items before we start to talk about scheduling our next meeting? So it sounds like no. So thinking for our next meeting, of course. course, since you're all here, then it makes me think that this date and time generally works for you. So I would ask if, with that in mind, if the second Tuesday in February is Valentine's Day, and you might have a date. You might not have a date at 10 in the morning, though. Do we wish, or maybe you do, in which case that's great, but then you have to speak up so that then we don't schedule a meeting for that time. So I'll ask, does February 14th, which is a Tuesday at the same time, work for you? Maybe. Okay, so I see 3 people's head nodding, which is great.
So Eileen, I just want to, I think February 14th is great. I just need to give the caveat that I may not be able to attend anytime during legislative session. And that's just a general caveat, because if I get called to a subcommittee or for any other reason, I may have to step away. But from a program standpoint, we will make sure that there are people available to support the meeting. I just may have to step away. And I say that every time, and 99% of the time I don't need to step away, but just need to make sure that that's present.
Thank you for preparing us. And of course, it won't be the same without you if you do get stepped away, and we'll be grateful for the great work that you're doing in the Roundhouse. And but I'm glad that generally speaking, we think that probably this will work out. Gary, would that time work out for you also too?
That should be fine. Yes.
Okay. Great.
Yeah, I don't see myself getting called to the Roundhouse, and so I would likely be here on the meeting. So.
Oh, good. Thanks. And maybe I'll ask if there's anyone who knows it doesn't work out for them. Okay. So it sounds like that we can that we'll have that date and time. Thank you. Okay. So I think that then it's that now we'll conclude the meeting. I really want to thank everybody here. I think you're I'm so grateful for everybody's thoughtfulness, also their commitment to New Mexicans, to each other, to this time. I hope that everybody is good to yourselves, as good as you are to other people, and if not as good as that, then at least half as good as you are to other people. I wish you a holiday season and new year that has health and happiness, peace and joy. And take good care, and looking forward to working with you again. Thank you.
Thank you, everyone. Happy holidays to everyone.